Good evening, everyone. I welcome you all for today's presentation. Thank you so much for your all time, and we'll start with the presentation. And today's topic is artificial intelligence in oral cancer, and we have our guest lecturer with us. So, I welcome Dr. Hitesh Singhavi. I am Dr. Meenal Sharma, MDS and senior resident at Muskan.ai. And here we are going to have a discussion and overview about oral cancer, which is the most common uh, cancer in all over the India. It is a fifth number in all cancer. So, Muskan, we are a team of doctors and engineers. We want to reimagine and redefining the dentistry and oral health care, and we have an ecosystem which is bridging between dentistry and technology. So that is artificial intelligence and machine learning, which we want to come or we want to share a platform as a ecosystem for the innovation in dentistry. And Muskan has four artificial intelligence product, and so we start from the oral cancer, oral hygiene, AI-based radiograph assessment, and dental GPT. So in coming time, we will discuss all of them, and we'll definitely uh, we have conducted multiple webinars on it, and we have our YouTube channel, and we shared all the information on that. And today, we are going to discuss about oral cancer in AI, how it is going to be changed in the prevention part, and gradually with the OPMDs and how it is going to helpful for the prevention and treatment. So without wasting time, we'll start with the today's presentation. And here we have, I welcome Dr. Hitesh Singhavi. He is a consultant as a facial surgeon, as a oncosurgeon. He is a rehabilitation oncosurgeon, simultaneously reconstruction oncosurgeon at Fortis and all other branches of the Fortis Hospital. And he has a 65 national and the international publication regarding the oral cancer. And here we are going to have his main, he will share his expertise and knowledge for the upcoming new topic, that is AI/ML. And he has an ex-research associated in the University of Minnesota, USA. He is a Maharashtra Cancer Warrior, and simultaneously he has been awarded as a Chaitra Navratna Award, and he has been author in one of the books that is being called the Comprehensive Management of Head and Neck Cancer. So, thank you so much, Dr. Nitesh, and I welcome you all, and I welcome you on our platform from complete team of Muskan.ai, and we can start with the session. Yes, sir.
Thank you, Meel. Thank you for the grand welcome. And also, at the behest, I also would like to thank all the team at Muskan AI. You're doing a great job of getting the AI into dentistry. Of course, oral cancer is part of dentistry, but a lot of other parts which you have already highlighted in your previous slides, and where AI can help us, can help the young individuals to get to the same experience of a well run of the mill practitioners. So without wasting much time, I'll just share. Yeah, let me know if it works. So is the screen shared now?
Yes, sir. We can see the screen.
So should I start? Yeah.
Yes, sir, we can start now.
Yeah. So today we'll talk on artificial intelligence and oral cancer. So first we'll start with why are we so focused on using this technology with oral cancer is because it is just a minute. I'll just cover the contents. Contents is first we'll check about why we are choosing oral cancer. So it'll cover the epidemiology part. What is the importance of screening in oral cancer? Importance of mouth self-examination and how we can use AI to screen these oral cancer even in mouth self-examination. When I say mouth self-examination, that means even the lay person will be able to use AI for examination of mouth, AI in screening and diagnosis of oral cancer, in biopsy and histopathological examination, AI in radiotherapy, and of course, what are the limitations and concerns in usage of AI? So, oral cavity is one of the most common site of head and neck squamous cell carcinoma. By 2012, whatever number we have is 3 lakh individual die globally and 1.5 in India. And it's predicted that by 2025, these number will increase by 10 to 15%. And India is called global oral cancer capital because India has more than 1,35,000 new oral cancer cases arising every year. And unfortunately, 50% of all those newly diagnosed oral cancer cases, they die within first year of diagnosis. 60 to 70% of these cases they present to us in an advanced stage. That means even after treatment, the survival is close to 60%. It is 40% of even those individuals who we treat, they do not make up for more than 1 year. So our aim is to catch them early because survival of early stage cancer is more than 90%, and also the morbidity or the deformity associated with early stage cancer is significantly less. Now we'll also focus on why are we having so much burden of oral cancer in India is majorly because of rampant use of smokeless tobacco. And many of the people who are today here with us may not know that even areca nut, that is supari, is a class 1 carcinogen. That means that means even areca nut can singularly, independently cause oral cancer, independent of tobacco. Also, alcohol is a class 1 carcinogen. Upper three are the etiological factors, fourth and fifth are the contributory factors. And I want to show you these numbers because these numbers is a data of, it is a systematic review or a meta-analysis. When I say meta-analysis, that means a lot of studies have been pooled and they are analyzed. And the pooled data have come off of many studies saying that the combustible tobacco can cause 3 times, 2 times, 6.7 times higher chances of upper air digestive tract, nasopharyngeal and pharyngeal cancers. Similarly, what about smokeless tobacco? Now, in Indian subcontinent, if you see, according to GATS is a global adult tobacco survey, it was conducted in 2015. WHO monitors it. 48% of all the adult males, that is almost half of all the males in India, they consume tobacco in some form. Similarly, for females, is 20%. And if you take the population of India, it is close to 30% of all the adult Indians, that is 30 crore individual, they consume tobacco in some form. That means these Indians who consume tobacco have higher chances of having oral cancer. Now, what are the chances? It is 5 times higher chances of having oral cancer as compared to the individual who do not consume it. And just to give you a number, when you combine tobacco with areca nut, it is 7 times. But even without tobacco, it is 2.8 times. So even areca nut without tobacco is as carcinogenic. This is just a global map where the green color gives you the market of areca nut, and the shadow now gives you the incidence of oral submucous fibrosis, how close, coherent, and congruent they are. Higher the market of areca nut, higher the incidence of oral submucous fibrosis. Similarly, alcohol, both international and Indian studies have shown that they cause oral cancer. Other contributory factors are chronic mucosal trauma, poor oral hygiene. Yes, viruses cause oropharyngeal cancers, but not oral cancers. So, why I have been concentrating on systematic review, pooled data analysis, pooled OR ratio is because the next step is how you can use this data. I'll come to that later. Next is screening, where AI can help. Screening involves systematic visual and physical examination of intraoral mucosa under bright light for signs of OPMDs and careful inspection and digital palpation of neck. Now, see the number. This study was done long back in 2005, published in Lancet, in four villages of India, consisting of 1 lakh population. 1 lakh individuals approximately participated in this study, and what they found was effective screening in high risk individuals. So screening is this part. High risk individuals is what we have discussed in the past slides, that we are high risk individuals, can lead to saving of 37,000 lives every year. So just by screening, 37,000 lives can be saved. Now screening can be by a doctor, and in the future I am thinking AI will do the screening. Same study was followed up for 15 years, and the high risk individual who underwent 4 rounds of screening, there was 38% reduction in mortality, sorry, in incidence of oral cancer, and 81% reduction in mortality. Now next is I want to concentrate on mouth self examination. So it is same as mouth examination by a doctor, but here the individual is made aware, is trained to self examine. Now self examine is not my concept. It has been effective, proven effective in breast cancers. Now whether it is effective in mouth self exam in the mouth, there is Indian studies as well as international studies saying the specificity rates are as high as 87.4%. Of course, sensitivity rates are low, which we can gain by educating them and making them aware on how these lesions look. This is a small video which I have made to mouse self-examine, and after this we'll concentrate only on AI, so that we know we are high risk individuals, we know screening helps, we know mouse screening helps. Now how we can translate this knowledge to AI so that it becomes easy and accessible.
Uh, Dr. Hitesh, can you share the computer audio because we are not able to.
Oh,
The audio is off.
just a minute.
Yeah.
Computer already shared. Stop sharing.
No,
I'll
no.
share again. Include computer sound, screen.
Reshare and select
can solve
computer
this
audio.
purpose. So early detection is possible only with knowledgeable mind and alert eye. इसीलिए आपको आंख और दिमाग दोनों को ट्रेन करना पड़ेगा. ब्रेस्ट एग्जामिनेशन में सेल्फ ब्रेस्ट एग्जामिनेशन हैज वर्कड वंडर्स. इसमें अर्ली ब्रेस्ट कैंसर्स को हमने जल्दी से डायग्नोस किया है. सिमिलरली हम माउथ एग्जामिनेशन करके ओरल कैंसर को भी अर्ली डायग्नोस कर सकते हैं. सो माउथ सेल्फ एग्जामिनेशन के लिए हमको 4 चीज़ों की ज़रूरत होती है. एक टॉर्च, गॉज, स्पून एंड मिरर. ये सभी चीज़ें आपको घर में मिल सकती है. टू स्टार्ट विथ द फर्स्ट स्टेप इज टू एग्जामिन योर लिप्स. तो लिप्स क्या होता है? बाहर की परत में जो भी आपके बॉर्डर्स है उसको एक बार कांच में देख लीजिए या हाथ से फील कर दीजिए. इफ देयर इज एनी अनइवननेस और एनी नॉन हीलिंग अल्सर दैट कैन बी डेंजरस. सेकेंड स्टेप इज दोनों हाथों से आपके लोअर लिप को से खींच के नीचे कीजिए और अंदर की परत देखिए और फील कीजिए. सेम चीज आप ऊपर की लिप को दोनों हाथों से रोल करके ऊपर की तरफ खींचिए एंड अंदर की परत देखिए और फील कीजिए. स्टेप 2 इज बकल म्यूकोजा, ऑल्सो नोन एज चीक म्यूकोजा. इसमें हम क्या करते हैं? अगेन इंडेक्स फिंगर को लेते हुए नीचे से रोल करते हुए ऊपर आते हैं और कॉर्नर ऑफ द माउथ से लेके पीछे तक, जहाँ की पिछला दांत है वहां तक आप पूरा राइट और लेफ्ट साइड एग्जामिन कर सकते हैं. स्टेप 2 एग्जामिन करने के टाइम हमको बहुत ध्यान रखना है, स्पेशली उन पेशेंट्स में जो तंबाकू, बीड़ी, सिगरेट पीते हैं. जहां तंबाकू रखते हैं ये स्पेशली चीक म्यूकोजा और बक्कल म्यूकोजा में होता है. इसके लिए जहां पे आप तंबाकू रखते हो उस जगह को अच्छे से एग्जामिन करो एंड चेक फॉर एनी रेड एंड white lesion or any non-healing ulcers which is more than 3 weeks old. Step 3 is examination of your gums, जो कि होता है मसूड़े. ऊपर के और नीचे मसूड़े जो आपके दांत को पकड़ के रखते हैं वो भी एक पार्ट है आपके ओरल कैविटी का. Even those areas can have non-healing ulcers और bumps और lumps जो आप अपने हाथों से रोल करते हुए नीचे और ऊपर के मसूड़ों को फील कर सकते हो. Apart from India, tongue cancers are the most common cancers in the global scenario. तो इस ऑर्गन को एग्जामिन करने के लिए आपको गॉज और अपने इंडेक्स फिंगर और थंब की जरूरत होती है. टंग को आपको बाहर खींचना है और राइट और लेफ्ट मूवमेंट को करते हुए राइट लैटरल बॉर्डर और लेफ्ट लैटरल बॉर्डर टंग को एग्जामिन करना है. सिमिलरली आपको टंग को नीचे लेके जाना है पीछे का भाग देखने के लिए और ऊपर लेके जाना है नीचे का भाग देखने के लिए. सेम आपको एग्जामिनेशन करना है अपने हाथों से भी फील करते हुए कि वहां पे लम्स, बम्स या कोई नॉन हीलिंग अल्सर है या नहीं. स्टेप 5 इज एग्जामिनेशन ऑफ फ्लोर ऑफ द माउथ. इसका मतलब क्या होता है? जबान के नीचे और दांत के बीच में, लोअर दांत के बीच में जो एरिया होता है उसको हम फ्लोर ऑफ द माउथ बोलते हैं. ये एरिया में स्पेशली जो अल्कोहल रेगुलरली लेते हैं ये एरिया में उनके यहाँ पे अल्सर्स या कैंसर होने के चांसेस होते हैं. इसको एग्जामिन कैसे करना है? जबान को आपको गॉज को पकड़ते हुए ऊपर लेके आना है और नीचे चेक करना है कहीं आपके नॉन हीलिंग अल्सर या कोई लम्स या बम्स है या नहीं. स्टेप 6 इज पैलेट, ऑल्सो नोन एज ताड़ू. इसको एग्जामिन करने के लिए आपको आपकी गर्दन थोड़ी सी एक्सटेंड करनी है और मिरर में देखना है कि जो आपकी दांत की ऊपरी दांत के पीछे का भाग है वहां पे कोई अनइवननेस या रेड और व्हाइट पैचेस है या नहीं. स्पेशली जो बीड़ी उल्टा पीते हैं जिसको हम बोलते हैं रिवर्स सिगरेट स्मोकिंग, उनमें पैलेट में नॉन हीलिंग अल्सर्स या रेड एंड व्हाइट लीजन होने के चांसेस बहुत ज्यादा होते हैं. स्टेप 7 इज एग्जामिनेशन ऑफ टॉन्सिल एंड बेस टंग. सो टंग की पिछला भाग हमको एग्जामिन करना है. इस एग्जामिनेशन के हमको स्पून की जरूरत होगी. स्पून से हमको टंग को थोड़ा नीचे डिप्रेस करना है और आ बोलना है. ये प्रोसीजर से आपको टॉन्सिल और पिछला भाग दिखाई देगा. इसमें कोई भी आपको लाल परत, नॉन हीलिंग अल्सर या रेडनेस दिखाई दे That can be the area which you need to be examined by a doctor. थर्ड, उसका जो सेकेंड पार्ट है दैट इज नेक एग्जामिनेशन. जो आपने अभी मुंह का पूरा एग्जामिनेशन कर लिया, कोई भी ओरल कैविटी कैंसर होता है 30 से 40% चांसेस ये होते हैं कि वो गले में फैल सकता है. इसके लिए गले में भी गांठ बड़ी हो सकती है. कभी कभी बिना ओरल कैविटी कैंसर के अल्सर के लक्षण के सीधे गले में भी आपको गठान समझ सकती है. इसके लिए नेक एग्जामिनेशन भी बहुत इंपॉर्टेंट है. आपको सिर्फ अपने दोनों हाथों से रोल करते हुए ऊपर से लेके रूट ऑफ नेक तक एग्जामिन करना है. उसमें कोई भी लम्स या बम्स आता है तो आपको डॉक्टर से कंसल्ट करना है. 20
So now you have seen the how self-examination can work in high-risk individuals. Now we'll see how we can. So these all techniques are to train a dentist, train a physician. Now step is how to train for all these problems a machine or something we call as artificial intelligence. Now, artificial intelligence is broadly divided into machine learning and deep learning. I'm not the expert to tell you what artificial intelligence is. I'm here to tell you how we can make this thing work. So, machine learning and deep learning, there's some differences. The first, the artificial intelligence is a branch of computer science concerned with building smart machines that can perform tasks which typically require human intelligence. Example is use of image analysis technique to assess and detection and classification of oral lesion. Now, what is machine learning? Machine learning is ability of the machine to learn information and patterns directly from data without being programmed explicitly. That means it follows the pattern which it is fed from data. Example is machine learning models can be trained on large data sets of patient information to develop a predictive models for treatment of response to oral cancer. Now, what is deep learning? Deep learning is a field of machine learning in which artificial neural networks with multiple layers learn from input data without supervision. So for a lay person, the main difference between machine learning and deep learning is that deep learning may be unsupervised, while machine learning usually is supervised. Now, for example of deep learning is convolutional neural networks, which have been employed to automate or enhance the analysis of histopathological slides in oral cancer. Now, how it can be done is, now we have just shown you the flow diagram where, for example, if you want to use AI for image identification, there you have to acquire images from various public database, hospital, health record system, medical devices, of course with the ethical permission, process it through image enhancing operations. You have various medical segmentation imaging programs, image analysis and feature engineering, and then after selecting the deep learning algorithm, that is, you know which red lesion is erythroplakia and which red lesion is aphthous ulcer. So we need to have thousands of erythroplakia added to the data, thousands of aphthous ulcers added to data, and manually check each and every one on which is erythroplakia and which is aphthous ulcer. And after some point in time, that intelligence will learn on its own to detect the erythroplakia and differentiate it from a non-malignant or a benign lesion. That is the essence of using artificial intelligence in image related, I would say, screening. So here you feed data, then you test the model internally. So with the same data set, you test the model, and then after that you test with an external validation. That means you test that model with a data from outside your institute or outside of data set and check if it is repetitive, if it is reproducible. If it is yes, then it has a potential for use in clinical or a real world setting. So in previous slides also I've spoken about a lot of numbers, a lot of systematic review. A step ahead of systematic review is a nomogram. Nomogram is assigning value to the risk factors. Now, example, tobacco chewing is a risk factor for oral cancer, but assigning value along with other risk factors like alcohol, like chronic mucosal trauma, like male in certain subcontinent. So assigning values in a relation to the other factors is called as nomogram. So nomogram is a step little ahead of meta-analysis and a step closer to AI. That means if you search nomogram and oral cancer, there are already 192 nomograms available in last 3 years. That means data is available in the literature. It is just there to be processed to the artificial intelligence. And studies have shown that AI will score better than nomogram even to predict overall survival for patients with tongue cancers. So that means AI is already better than nomogram if it is fed with data with right data set. This is a beautiful diagram by one of the papers in Journal of Pathology. It was published in 2021. See, it shows the progress the artificial intelligence has made in different section of oral cancer. I would say head and neck cancers. Now, if you see the longest spike is in oral cavity histology and oral cavity infrared. Also, oral cavity clinical imaging is somewhere at 2. Nasopharynx rheology is somewhere at 3. So this is the beautiful diagram where you'll be able to understand which part of all of head and neck cancers AI has already taken a lead, while there are few parts where it is still in the incubation stage. So now we'll go to depth on in which stages and how does AI influence the oral cancer treatment, screening, management, surveillance, and what are the evidence already available in the literature. So it can influence diagnosis, it can influence screening, it can influence histopathological reporting, radiology, that is imaging, that is CT scan, MRI, IOPA, OPG, OCC treatment as well. Yes, oral cancer treatment, surgery as well. It will take some time, but yes, it can influence. Adjuvant treatment, including radiation planning. I'll come to it in the later slides. And also in surveillance. Now, this is what I call as machine learning. This is not deep learning. This is machine learning. It is already available on site. Now, I'll click in front of you. I'll click this slide. I think it should go there. Oh. So it's taking time. So here, what they have shown, they have given us a lot of risk factors which influences oral cancer. You feed in the information. That means you take an individual, they have their own data set. You feed in the individual information. This is for the malignant transformation rates. So once you fill the data, on the right side, it will show a graph. What it shows is 50% of all these kind of individuals, they will develop malignancy by 45 months of their, I would say, 45 months of their biopsy. Yeah, it's going there. Yes. Is the screen shared? Okay. So I'm entering here 55, male, smoker, yes. Risk factor, yes. Head neck malignancy, no malignancy. Charlson 2. Hypertension, diabetes, yes. No hyperlipidemia, no autoimmune disease, no viral. Type of lesion is they have given. We can include more. So leukoplakia. Here it is, I would say, erosive. I'm just giving you a small example on how it can work in future for us. Number of lesion 1, 2, 3. Presence of ulcer, red, yes. Presence of intubation, yes. Surgical intervention, no. Number of recurrence, no. Dysplasia, I would say severe, yes. And it is using a deep serve model. Predict. See. So here it is showing that somewhere again at 45 months, you'll have highest malignant transformation rate. So more than 50% of the individual. But if you see at about 10 years, more than 80% might have converted. Of course, we do not know the data set on which it is based, but this kind of things are already there in the domain. We need to have our own data set for it to be reproducible. Now, next we move on to the very important part is assessment of medical image by an AI. Because for us, for screening, it is very important that we take correct for pictures, and it is taken in a way in which AI can understand or properly segment. So what is medical segmentation of an image? It is a computer vision task that involves dividing a medical image into multiple segments where each segment represents a different object or structure of interest in the image. The goal of medical image segmentation is to provide a precise and accurate presentation of the object of their interest within the image, typically for the purpose of diagnosis, treatment planning, and quantitative analysis. Now, if you see this slide, it's a busy slide, but it shows the spectrum on how the medical segmentation works. The first is lung. Now, they have divided the lung into three lobes. Here is skin, where the discolored part is separated from the healthy part. And similarly, it goes from imaging to histopathological slide to endoscopic slide and to the clinical side. So every image which you can take, which your eye sees, can be segmented medically for AI to work. Now we'll move on to the evidence. Now, what are the evidence available in the literature to say that AI has potential? I'll not say AI is useful in the real world setting, it's still to be discovered, but yes, it has immense potential. Now, if you see this first study by Song et al., it has 2350 number of images taken. They have differentiated these images into normal and malignancy, and the accuracy is as high as 90%. Now, anything of that accurate is eligible for real world setting, but there are of course a lot of caveats. We'll discuss that later. Now again, you see the fourth study, which is a Chinese study. More than 40,000 images were taken, and AUC, that is area under curve. So when I say area under curve is 95%, that means whatever prediction I'm doing, 95% of that data set follows. So 44,000 out of that 95% of the data set will follow the prediction of the CNN, which they have used, CNS convolutional neural network algorithm. Now next we move on to is evidence on histopathological diagnosis using AI. So here you see, of course, the numbers are not very huge as compared to the clinical images taken, but the sensitivity and the specificity is more than 90% in all, I would say, studies. Now you take the fourth study, Young et al., which I want to stress upon is because it has shown, now in this study there were two pathologists. One is less than 5 years of experience, which they have termed as junior pathologist, and more than 5 years of experience they have termed as senior pathologist. And here what they have discovered is the accuracy of the AI was better than a junior pathologist. Now what I mean to say is, I don't want to replace his job. What I mean to say is that AI is still young, but it can be useful for young individuals, for young practitioners, for those people who do not have much experience. And I think majority of the people who are there in the practice are still young, and they will need such technology for improvement of speed and accuracy of diagnosis. Similarly, these are studies which are available in literature, which have again shown the accuracy to be as high as more than 95%. Now see the seventh study, which has classified Broders classification. Now, if you know Broders classification of oral cancer, 4 grades, even in that, the accuracy was as high as 97.5%. Now, this you have seen the evidence, which is I would say abundant for histopathological and clinical imaging. Now, as far as surgery is concerned, there is still no evidence to say that AI can help you in the surgical, that is mechanical aspect of oral cancer treatment. Of course, there have been some papers on colorectal cancers where they have shown outcome, and in vivo, I would say in vitro studies, ex vivo studies, where John Hopkins University's this is called a STAR, Smart Tissue Autonomous Robot, where they have compared the suturing techniques with human surgeons, and they have found that the STAR outperformed the human surgeons. Of course, a lot of caveats to it, but as far as preciseness is concerned, because the same procedures performed in 57 minutes as compared to the human surgeons who did that in 2 minutes. So there are no caveats to this study, but the precision and the outcome was better for SMART, that is for STAR, that is Smart Tissue Autonomous Robot, as compared to humans. That means there's a potential if lot of data is fed to the algorithm of AI. Next is AI in radiotherapy. So AI in radiotherapy, so these are different stages at which the radiotherapy works. The first is treatment decision. AI can help collaborate, or I would say combine clinical, genomic, and imaging data to support precision oncology practice. It can reduce radiation exposure of patients, enhance image quality, suppress artifacts, and enable more accurate imaging registrations. Automated tumor and organ segmentation as well as optimal dose prediction promise to streamline the planning process. It can enhance image guidance, motion management, and scheduling, promise to improve clinical efficiency and patient outcome and experience. And lastly, accurate prediction of response to treatment. Radiation-induced toxicity and other adverse effects might provide real-time, meaningful clinical decision support. Now, advantage of this include is that radiation therapist can give more time to the patient. The turnaround times will be reduced. Medical physicists will be able to have more patient-facing role with automation of quality assurance, and dosimetrists will likely to focus more on complex cases as compared to common cases. So there are a lot of evidence, or I got more of evidence on imaging, histopathological diagnosis, even radiotherapy. Now you have seen the entire spectrum on where we already have evidence on AI, and also where we do not, that is in surgery and also in radiology. As far as oral cancer is concerned, there is little evidence. But along with technology, there are some concerns which we need to address. Concerns have classified into two parts. One is machine learning, and second is clinical concerns. Now, first we'll see what are machine learning concerns. First is something called as black box phenomenon. Is its inability on how the trained machine learning models make the diagnosis or prediction of the patient on case by case basis. That means, for example, an AI says this is oral cancer, but it is not able to reason out why it is oral cancer. It's a security concerns for us, because what happens is if you do not know why this is oral cancer, then there are chances if you get it wrong, then we will not be able to go back and correct it. That means the AI will keep on making the same mistakes. Also, result and model interpretability. That is, for example, tongue is a most common site of oral cancer as far as global scenario is concerned, but in Indian scenario it is buccal mucosa. So if your AI is built on the data set from Indian subcontinent, then buccal mucosa will be the high risk site as compared to tongue. But if the data is built on global scenario, then the tongue will be the high risk site, and both cannot be interchanged. That is where the problem lies. So if the AI is built on certain data set, it will be reproducible only to the individuals, to the persons who are like those data set. Now, one of the um, concerns I would examples which I saw on the, of course, on the net only, that face recognition algorithm AI uses a lot. Company uses a lot of AI in face recognition algorithm, and there are few cases in the Western world, even US, I've seen that the AI has wrongly recognized a person, which has led to the jail of that individual. Now they tried to find out what was the reason behind it. The reason behind it was the data with which that facial algorithm AI was made was for non-color individuals. For colored individuals, the sensitivity and specificity significantly dropped, and that is the reason why AI made that mistake. So it's very important that the amount and the quality and the interpretability of data of that AI will govern the diagnosis as well, as far as oral cancer is concerned. Then generalizability of the model is also a concern. There's also an ethical concern. Now, for example, I think Amazon uses the AI for shortlisting the job interviews. Now, even in that, there were examples. Nowadays, Amazon's in fact have stopped using AI because it was biased towards male. Now, the reason which they gave, I think you can find out on the internet, that they were biased towards male, and that is the reason why even the AI can have ethical concerns, biases involved with AI. Now, this is the example where how wrongful arrest based on AI derailed three men's lives. It's available on net. Now, these were the machine learning concerns. There are also clinical concerns. Clinical concerns include the explainability of the machine learning. Something is called as explainable AI. You need an explainable AI where any diagnosis, as far as oral cancer is concerned, or any dental disease is concerned, or any disease is concerned, the AI should be able to explain on how it came to diagnosis. Second is change of patient clinician relationship, where a patient will not be able to have same kind of relationship with the doctor when AI comes in. Additionally, superhuman analogy, the assumption that diagnosis or prognosis by the machine learning algorithm is close to perfect or even better than performance of clinician. And of course, job competitor, it concerns the adoption of machine learning would replace the pathologist or any other clinician for that matter. Also some challenges for adaptability of the AI. So this is a beautiful diagram which one of the articles have included, where what we want is a central black box where the AI can be trustworthy, AI should be explainable, it should be interpretable, and should be transparent. And the other boxes which you see are concerns which we need to address. So these are different lesions which you see in the oral cavity. If you ask a fresh pass out, or even for that concern a fresh, I would say postgraduate, he might make a mistake. But if an artificial intelligence algorithm is being fed with this data, then they will seldom make a mistake. So what I mean to say is artificial intelligence currently have a place for upcoming individuals who are not exposed to these kind of cases or lesions in their training. To summarize, AI powered can be a paradigm shift in oral cancer screening system. AI powered histopathological analysis can analyze the slides and identify lesions even sometimes better than junior pathologist. AI powered prognosis prediction can analyze patient data with tumor characteristics and predict likelihood of recurrence and survival, which is so lively on the internet, which one of the data set shows the median transformation rate of certain leukoplegia. AI-powered drug delivery system, which we have not discussed because I thought the medical oncology is not part of today's lecture. So AI-powered system can analyze large data sets of genomics and other molecular data to identify genes and proteins that are involved in oral cancer development and progression, therefore involved in targeted therapy. So overall, AI has a potential to significantly improve the diagnosis, treatment, and prognosis of oral cancer patients. Thank you.
Thank you so much, Dr. Hitesh. It was very informative to hear about from the how is the basic epidemiology of oral cancer till the insights of AI in oral cancer. I mean, overall the overview. And I must say that it was all evidence based. So I would like to take questions from the doctors who has joined us, and they have given their valuable feed time. Yeah, so Dr. Tripti Shah has a question that has AI started being used in real world of India, and how can anyone get started if one want to use AI in oral cancer?
So, as I've already mentioned in my slides, it's still not in real world setting. AI is about data and robustness of data. We need robust data. We need a lot of centers to combine and give that data and then make an algorithm based on that data set to be applicable in the same population. So we're still in that, I would say, scenario where uh, I would say we are in edge scenario where 5-10 years back we were on edge. Today we are on 5G. We are on edge scenario, of course, but there is a lot of potential in AI with with um, with solving all those concerns which we have, which I've already discussed. I think it should be in real world setting in next 5 years.
Yes, sir. And sir, here I would like to add one point that oral cancer has various types, and if uh, if we can detect the OPMDs, so with AI, and there are huge classification for the OPMDs. If we can detect and we can have that kind of data set, because each part of India has the different types of specifically OPMDs and the oral cancer. So I think if all together, if we all can join hands on, say, one platform, so I think it can change the complete scenario regarding the oral cancer.
I completely agree with you that we need ethically approved data set from different centers in India to make AI work. And very
Yes.
importantly, AI will only work in common lesions. It will never work in rare lesions. And India is a global oral cancer capital. We have a lot of oral cancers, and therefore we'll have a lot of data on oral cancer and oral potential many disorders. And therefore, the AI which comes out from India on these lesions will be the best enabled data set.
Yes, sir. So, any other questions? And Dr. Tripti here, I would like to inform you and what would like to share that Muskan has already started working with the AIMS Mohali and PGI Rohtak towards more accuracy result for the AI in oral cancer. I think we have shared that platform with Dr. Hitesh also, and I'm sure that he will share his insights uh, towards the application we have made it, and I am sure that it will take some time, but it will come on the very good positive results toward it, where we can, if early detection, though it is because early detection will be done for the screening only. If we are not focusing on more and more screening, so it might be we can miss a lot of lesions, because oral lesions are more usually it comes to the dentist first and then any other specialist. So I'm sure that we have already started with the two pilot studies, and we have submitted the project in ICMR. So I'm sure. So we'll soon see the results from Muskan, and with other expertise like Dr. Hitesh Singhavi and other experts.
I am hopeful. I'm hopeful that we will definitely do justice, and of course, we should capitalize on what is coming in the future.
Yes, sir. So, and sir, any as per, I mean, according to your opinion, so oral pre-malignant lesions, so how it will be useful, I mean, AI to detect those lesions, or maybe it has a difficult task because it has a huge variety.
So, see, so whatever research and review I have done for artificial intelligence, what I feel is it is um, you'll get the output on what you feed. So you need to have good feeding material to have good output. And I think we have a lot of feeding material. We have a
Yes.
lot of oral cancer. We have a lot of, unfortunately, we have a lot of OPMDs. We have a lot of variety of leukoplakias. We have heterogeneous leukoplakia. We have homogeneous leukoplakia. We have nodal leukoplakia.
Okay.
We have lichen planus. Even lichen planus, we have 6 types of lichen planus.
Hmm.
Erosive, vetrophic. There are many types also in leukoplakia.
Hmm.
And so if we have a good data set, and this is an image analysis. There's another called as ANN, artificial neural network, in which we add data. So we also have data set. That means, for example, a person is a gutka chewer for 5 years, since frequency is about 10 times a day. So the chances of it having OSMF will be more if the person is having gutka for more than 10 years and frequency is 20. So AI will give me an approximate, I would say, an idea on what are the chances of melanin transformation according to the habits and frequency. That means we will be able to customize the tendencies of you having any kind of cancer, oral cancer in this matter, if you're having some kind of risk factor, if you're having some kind of risk factors. So it is not only about image analysis, it's also about the data set accompanied with the image analysis. And the third, it will be genetics. The combination of clinics, image analysis, radiology, and genetics, I think it will be uh, more accurate than any practicing surgeons at that point in time.
Yes, sir. And one more question we have from Dr. Anil Patak. AI is quite promising and it has huge adoption in US and other countries. What is preventing us to adopt and accelerate application of AI in Indian healthcare system, especially for cancers?
So this is a very nice question, which I think, sorry, I didn't get the name.
Dr.
You
Anil
mentioned which?
Patak.
Anil
Dr.
Pathak.
Anil Patak.
Very nice question, because see why it is not been accelerated. Not in India, I would say healthcare system is because of the privacy concerns, the data privacy concerns, the confidentiality of data. Now, for example, I want to identify this as a phone and this as a bottle. They don't have privacy concerns. I can take as much photographs, as many with many angles, so that we get an accurate, I would say, identification of the object. But when you come to humans, it is a lot of concerns, HIPAA concerns, I would say, confidentiality concerns. Getting the data set is also a big achievement. So when you want to get data from a big institute, it's also a big achievement. And then data breach concerns. That means now you've got a data set, and there are high chances there will be a data breach from that. So even AI can breach the data. AI can inadvertently reveal certain things if it's not programmed well. Now, for example, a chat box was made by, I think, Twitter, or I don't remember. Chat box was made to prevent racism. Within 16 to 24 hours, the AI started, um, I would say, taking data or taking experience while it was talking with the individuals who are racist. And in 24 hours, even those that AI started giving racist comments. This is very important. Technology is a double-edged sword. If it is not taken well in the right way, it can cause more harm than it will benefit. Now, if you know, US has banned one of the social media platforms in 12 states. That is how problematic the social media is for the youth. That is how diverting it is. And this we know now after 30 years of internet. Now, if you go back 30 years, 40 years, when the internet was not available, and then when someone says that these are all problems you'll have in the future, you should ask the question whether you will lay the internet so easily to everyone. So AI is of course promising. It will replace many humans or human intelligence in a common work, like common detecting lesion, like usual work, but it will make a human intelligence weak. It's very important that we know it has immense potential, but we should train it, we should tame it now so that doesn't become a, I would say, double-edged sword which harms us more.
Right, sir. Absolutely correct, sir. And we have one more question, that can oral diseases be prevented if not eradicated completely with image analysis for OPMD? Also, what are your thoughts on how long it will take to bring it down to at least 1% cancer belt region? So,
Okay, we'll take for the first question. I might, you mind repeating it?
yeah, can oral diseases be prevented if not eradicated completely with image analysis for OPMD?
So first of all, image analysis is not the treatment, it's for diagnosis. So yes, we should be able to diagnose many of the oral diseases, many of the common oral diseases for now. Now, as far as oral disease is concerned, oral cancer is part of the oral disease. There are not oral diseases apart from oral cancer. As far as you eat, you cannot eradicate oral diseases. So you may not be able to eradicate it. You'll be able to control it. You'll be able to diagnose it early. Diagnosing it early will lead to earlier treatment, less morbidity, and less mortality.
Yes, absolutely. Because that is why nowadays we have more focus towards the more and more screening, because initial stage of oral cancer and the lesions are asymptomatic. Uh, right. So if at all, if it, because patient says if like you told the self examination, that was very good part, sir, I must say. And if at all, sometimes unless and until it is not giving pain in the daily routine life, patients are not actually bothered, or they don't take much care about it unless and until they are not able to have food or good food. So, and completely agree with your point, sir. And any other thoughts towards like screening, or how the screening or the AI can helpful for the screening part, where the general dentist, the the clinician can use it, AI in oral cancer screening. Maybe it can be
So
helpful on.
every dentist already has an artificial intelligence probe.
Yeah.
You know what it is? Every dentist has an artificial intelligence probe.
Okay.
This is the probe. So smartphone is a probe which you will be able to access the oral lesions. Of course, the mouth opening should be good.
Yeah.
Even for the individuals who have reduced mouth opening, there are contra-angle probes which we can design or which are already available in the market, which will
Yes.
help
Yes.
in taking the pictures well. I do a lot of endoscopies
Okay.
via nose. So if the mouth opening is reduced, I am not able to see the posterior extent of the disease. I make
Okay.
use of the camera which goes from the nose and it reaches the base of the tongue to see how is the base tongue. Even that can be used as a data set for image analysis. So I think we are just step or two away from using artificial intelligence. It's all about building robust data, and we'll need help from Rajiv, we'll need help from Dr. Meenal in getting those algorithms in place. And then, of course, we can AI will be just another software on any other mobile.
Yes, sir. Yes, sir. Thank you so much for your insight, sir, because that is why when we were planning, we had planned the application for especially for the clinicians on Muskan.ai. So that is why we have kept as a tool for the mobile phone, so that it is mobile is one thing. Everyone, most of the people, it's a simple Android phone. We have kept it so that it is easy to use, and images can be clicked by anyone and from anywhere. So that is why we thought, instead of taking, because I think for the AI there are different types of tool has been used in the various studies. So when we were going through all the studies, we thought that let's not give any other investment or any complicated things. So we have, the Muskan has the clinical images and and the history, obviously, because in oral cancer history is very important, so that we can guide a patient and we can use it for the management. So, and that is why here I would like to add on one point, that as of now we have a accuracy of 82 to 84% by AI, and with our algorithms, it is still in process. And I'm sure that if I can see all the surgeons, dentists, and whosoever is joined, so I request that if at all anybody would like to use or have to take a trial of this, and Dr. Tripti. So you can contact us, and I think we can say that how the AI is working. It's in a very initial stage, but yes, the basic things are ready. So any more questions? Let me just see, sir, once in the question and answer section.
I think Dr. Arvind had raised his hand. I don't know.
Yeah. Anitya, can you see the Dr. Arvind would like to speak, or he has question? Because I cannot see his question here.
He has the mic permission.
Okay. Dr. Arvind, can you take your question, please? Dr. Arvind, am I audible or? Okay. So, any other questions, so that we'll respect everybody's time, and so that we can end up the session. Any more questions?
We can take comments from Rajiv.
Yeah. Rajiv, are you there?
Yes, Dr. Meet. Dr. Hitesh,
Yeah.
I'm here. I will just turn on my camera. Give me 1 minute, I think. There's some echo on my side.
We can hear you properly. I think there should, it's not problem from.
No, first of all, I thank Dr. Hitesh for taking the time topic which should have a discussion with you about explainable AI. And I
Uh,
don't know if you know, Nitya, we have a book on explainable AI.
uh,
We
Rajiv,
already
just a minute. I think you can check the settings. Yes, I can. The echo is there from your side, so we are not
okay.
hear you properly.
Let me get back. You guys continue.
Yeah. And thank you so much, Dr. Hitesh sir, you for your valuable time, and I really appreciate it because sir is very busy with his practice and in the Mumbai in such a hectic schedule. He has taken a time, especially on the Saturday, and I'm really thankful to you, sir. I really it is a great pleasure, and I'm sure that if we can get soon your association on the Muskan. It will be great, and I'm sure that with your expertise on our AI expertise, we can have better results and more accurate results by AI.
Absolutely. I think
Yep.
this is a need of the hour.
Yes, sir. Because
Yeah.
usually we get questions that AI will replace. I mean, how it is helpful, or humans are, or the doctors are much more efficient than the AI. How can they rely on AI? So these questions we are usually getting from many platforms from many people. So I thought your insights will be very helpful for our audience. Yes, Rajiv, please go on.
Yeah, so no, I absolutely agree with you. Dr. Hitesh, first of all, thanks for your time and the points that you mentioned, all the way from the accuracy to the ethical or the black box, including the explainable AI. Those things are very critical. And one of the things that I was telling, which just reminds me, Anitya and I, we published a book also on explainable AI. We have 25 models, and those models only focus on the explainable AI. And the reason we did that was because we do know that there's a bias. There's a bias in the ecosystem. I have a biases. All of us on the phone, or sorry, on the call, no one can say that they don't have a biases. The bias can be as simple as towards the taste buds, the color,
Correct.
right? So I do agree that there's a lot of scope. I do like the question of Dr. Anil Pathak. I don't know if he's still on the call. There's a lot of scope for doing the R&D and doing a lot of analysis in India, and I think that is where we are partnering with experts like Dr. Hitesh and many others to how we can advance the adoption of AI for especially for India. And I do know, and I'm confident that over a period of time, we'll continue to advance our research, our inputs in the field of cancer, specifically, not only just the oral cancer. We had some discussions with Dr. Hitesh also on the other cancer models that we have built, and we'll continue to do whatever best we can do, provided we get support from each and every person on this call, especially the people who are from the medical fraternity. Engineers can build the things, but we need guidance, we need support, we need inputs from the medical experts. Okay. So, any other questions? And if not, Dr. Meenal, we can wind up. I want to be respectful for everyone's time.
Yes. Okay. So I think if audience has any questions, so they can visit us info@muskan.ai, and we have their email ID. And this session has been recorded. So the Dr. Hitesh will he can share on his YouTube channel also, and because we have our own YouTube channel, so we can have multiple whoever has missed it or who wants to see it, who want to reach out to us. So they are most welcome. And thank you so much, Dr. Hitesh sir. And let's hope for the best in coming time. Within some time, we can have a panel discussion with few other experts also.
Absolutely. Pleasure is mine.
Yes, sir. Yes, sir.
Thank you,
Right,
Rajiv.
sir.
Thank you, Dr. Minal. Thank you all.
Thank you.
Thanks, Dr.
Thank you.
Hitesh. Thank you, everyone.
Good evening, everyone. Thank you. Thanks for joining us.